Hello, and welcome to CalHIPSO's monthly webinar series. My name is Lauren Russo. I will be today's webinar organizer. Thank you all for joining us today. All attendees are currently muted. However, we do hope to open the platform for discussion at the end of the presentation. In the meanwhile, should you have any questions, please enter them in the chat box, not the question box at any time. Today's webinar is being recorded. The slide deck and recording will be available on our website, www.calhipso.org. All attendees will receive a follow-up email when these materials are available for you as well. For today's webinar, we are joined by CalHIPSO's own DeeAnne McCallin. DeeAnne has been the resident subject matter on meaningful use since 2013. And with no further ado, I'm going to go ahead and pass the controls over to DeeAnne. DeeAnne, thank you, and take it away.
Thanks, Lauren. Thanks for joining us today, everybody. Today's topic is, can promoting interoperability be meaningful? We typically have our webinars once a month. We did not have one last week, the last week of April, because I wanted to have one today on May 7th. A lot of you probably know who we are since these slides are available. I'm not going to read through it, but CalHIPSO has been around for 10 years, and we were formed by the California Primary Care Association, California Medical Association, and the Public Hospital and Health Systems. Thank you to our founders, and 10 years later. Wanted to show you some of the things of what I've been up to during our stay at home. I escaped the house once to go out on a hike. That wasn't one of the 2 or 3 grocery store runs. We had to pack up the material that we had saved or had set aside for our conference that was supposed to be today. Done a little bit of planting with my little Kermit chia pet, which I found when I was pulling out the puzzles. I did not do the puzzle that's pictured here. My daughter did, but I'm the one looking for the missing piece. So if anybody sees it, let me know. And one other day, part of the family, I thought we were bouncing off the walls, so I sent them out to a orchard 45 miles away to bring home some apples. So we have a lot of apples to be peeling. So I wanted to give you a little bit of the personal over the last couple months about myself and what I've been up to. As I've mentioned, today was going to be CalHIPSO's Interoperability Conference, our 2nd annual conference. And it takes better part of a year to pull together a conference, and we'd like to thank all of the sponsors and our founding partners who have been working with David Ford and some of the CalHIPSO team since August of last year, and we do still plan on launching something towards an interoperability agenda later this year. And in the meanwhile, definitely wanted to give a nod to everyone, since we would have been convening today in Sacramento, but because we know we're all sheltering in place still, that was not able to happen. I'm going to pause right now to conduct a poll. We don't typically do this, but I felt it was time for me to jump into the polling arena. And Lauren, take it away from here. What type of healthcare organization are you with or do you work with? So if you're able to select one of these, of course we have the other category. I wonder if I'm allowed to. No. And Lauren, let me know if you're seeing anyone responding. You might be muted, Lauren.
Yeah, sorry, I was muted for a second. It looks like we do have a couple of answers rolling in. They're starting to slow down, so I'll give it another 5 to 10 seconds before we close it and pull up our results.
Great, thanks.
Okay, so if you're still answering, go ahead and get those answers in. I'm going to go ahead and close up the poll. And then we'll take a look at the results that brought us.
There we go. Excellent. Very good. So a good mix. 50% are from the actual practices and where the healthcare is happening, and 43% others. So I really like having that. Thank you for participating. You may close the poll, and I think that takes me back to the slides.
Absolutely. Here you go.
Great. My slide advancing seems a little slow. There we go. So today's topic, promoting interoperability, also known as meaningful use stage 3, and it still has a lot to do with HIE, so I wanted to keep that little picture right there. CalHIPSO's focus this year, so minus our conference, we are still continuing to build on an interoperability agenda, and in light of the pandemic, I really feel that that's more important than ever, having us being able to be interoperable. We are in the final months of the California Technical Assistance Program, so we are still helping folks with some of the 2019 meaningful use attestations that were submitted, and there is time for 2020 applications to be submitted to fall under the CTAP program. All of the 2020 applications will not be in before the end of the CTAP, but I have a little bit more detail on that. CalHIPSO is also working as practice transformation specialist field team for the Aledade Medicare Shared Savings Program accountable organization, which are also known as ACOs. So we have the 2 ACOs in California. This is their first performance year. And we're also out here to help spread the word on the Department of Healthcare Services California Health Information Exchange onboarding program, also known as CalHOP. The program is underway. It was approved by CMS late February of this year. Then right as it was about to really get launched, we ran into the coronavirus and pandemic situation. But there are things moving, and this website directs you to things if you haven't heard anything about this. This is a program that helps to bring HIE all the way to where everybody's been wanting it to get to in California. And it's funding for that 90-10 funding, where the federal government pays 90% and the California budget from a couple years ago allocated the 10%, and kind of pennies in the grand scheme of the cost of healthcare these days. A little disclaimer that CalHIPSO is one of the 4 contracted entities with the Department of Healthcare Services on the CTAP program. So CalHIPSO does earn some revenue for helping folks that are enrolled in the CTAP program under CalHIPSO when they achieve meaningful use. And there is a resource link to the CTAP program. Promoting interoperability is what CMS changed the name to a number of years ago. When that change first came, I did not like it at all. And just about in the last 6 months did I really start to embrace that title. And under promoting interoperability, it falls under both the Medicaid meaningful use and also the quality payment program MIPS part. So the Medicare meaningful use program ran from 2010 through 2016. The Medicaid program started in 2010, but it's still open, and it goes all the way through September 2021. You did need to be in the program with at least one successful attestation, whether it was adopt, implement, or upgrade, or meaningful use by the 2016 program year. And when I say you, I'm speaking at the eligible professional clinician level. That there's a lot of organizations, a lot of big FQHCs that work, a lot of the ambulatory sites from the public hospitals, that if it drills down to the EP level. So if one EP was in with an attestation in 2011, they're in the program, they're allowed to continue in the program even if they might not have participated since then. If somebody looked at the program 2018 or 2020, but they never had a successful attestation prior to now, it's too late and they're not able to join. MIPS is part of the quality payment program, and it began in 2017. And one of the distinctions that I think is a great terminology that CMS adopted is they defined the participants as eligible clinicians. So the meaningful use program is eligible professional, and MIPS is eligible clinician, and that has helped me be able to know what, when we're reading guidance or somebody is making inquiries, to be able to help distinguish which program they're in. There are similarities between meaningful use and MIPS because they're both called promoting interoperability now. That's why I'm laying out this distinction, that they both need 2015 edition certs. Security risk analysis is part of it. They both have these stage 3 parameters to them, but there's also differences. So MIPS allows group reporting. Medicaid meaningful use allows group eligibility, but not group reporting. And meaningful use, the Medicaid side, is still all or nothing. If you fail one measure, then you unfortunately cannot pass meaningful use. Whereas on the MIPS side of the house, it's a lot more forgiving. Medicare, CMS learned a lot from the meaningful use program from the early years and brought some of those lessons learned into the MIPS program. But those of us still operating in the Medicaid meaningful use side are still subject to the all or nothing. Today, we're discussing the Medi-Cal Promoting Interoperability program, also known as Meaningful Use or MU. Henceforward through this presentation, I'll probably be saying only MU, maybe meaningful use some, but I'm probably not going to be going on with promoting interoperability until the end. Very broad strokes on the eligibility is that you need to have been in the program by 2016 program year. You need to have greater than 30% Medicaid billable encounters. If you're a pediatrician, the bar is 20%, greater than 20%. It also does reduce your incentives that you can earn. And the billable encounters can be determined by a group. So if you're a group of 10 clinicians and 4 of them have 95% and the other 6 have 10%, the math of that probably works out to greater than 30%. So that's where the group eligibility is a nice feature if it's needed. And it also tends to make, then you only have to prove this eligibility once as opposed to on the individual level. And then there is a maximum participation years, so it's 6 years. So if a clinician has started in the program in 2011 or 2012 and managed to do 6 consecutive years, they're finished. So they're no longer allowed to earn additional meaningful use. They cannot earn the 7th year, the 8th year. And if you skipped years, if there's an EP who was in the program and they did a couple years and then not again, they still have the remaining of 6. So there is a resource here, and I also have it at the end of the deck, where there's an open data portal where you can look up the NPI to see the history if you've been in the California Medi-Cal Meaningful Use program. And hopefully I'll be able to show you a sample of that, but that's one of the great ways. If you're really not sure, if you don't have time, you can send us via email your NPIs and we can look it up for you. And besides this open data portal, which is typically updated once a quarter, there's a little inconsistency. It might be faster nowadays. We can also look at some other resources to let you know, and we're also able to work with DHCS for them to clarify. And that's the other point, is that if an eligible professional worked in another state and was in their meaningful use program, they are still eligible here in California. If they were in the Medicare program, it's too late to switch into the Medicaid now, whether it was in California or in another state. So overall in the program, the allotment back when the rules first came out was $63,750 could be earned by someone participating through all 6 years. And this is just a resource to that. It's really precursor to what I'm putting here. So one of the reasons I'm having this meaningful use webinar today, when meaningful use is a bit of a dinosaur, it's still out there and there is still money on the table and there's still incentive dollars that can be earned. And we all know that many of you have been suffering from reduced revenue because of the stay-at-home orders and the fewer office visits, for a little while, lower reimbursement on telehealth, that I wanted everybody to know about the funds that are still out there. And so many people are so close to being able to get back into meaningful use. The scenario, Dr. Smith was in the program 2016 and 2017, so attested for 2 years. The $63,000 line is if somebody does all 6 years. And then let's say the organization's meaningful use guru left to go to nursing school, and so they didn't do anything in 2018 and they have since forgotten about it. guess what? You can get back into the program, and for 2020 program year, earn $8,500, and the same with the 2021 program year. What if you have 5 Dr. Smiths in your organization? That's the 17,000 times 5 is $85,000 you can earn, and you can be submitting half of that right now for 2020 program year. And what if you have 50 of them? What if you're a large FQHC or a large hospital system with the ambulatory EPs? So there's money available if you meet meaningful use. So that's why we need to make sure you're eligible to be in the program before I dangle the carrot for you for these funds, but they're out there. And then the next slide is the consideration of what if there were 2 extra years? So the funding of the EHR incentive program, which is what it was originally called, came from the American Reinvestment and Recovery Act, known as ARA, part of the High Tech Act. And in there is the phrase that says, in no case shall payments be made after 2021. That is why the program closes September 30th, 2021. To extend that, we would need an act of Congress. So what if we were able to extend it? Kind of no point extending it if nobody jumps back in the arena for program years 2020 and 2021, but it's something to contemplate if we have the need. Here's the remaining timeline. So for 2020 program year, submissions to the California State Level Registry, which I will now probably refer to as the SLR through the rest of this presentation, is open today. We could go in and submit an attestation because it's 90-day meaningful use reporting period and 90-day clinical quality measures. So previous year or two, 2018 and 2019, the CQMs, the clinical quality measures, were full year reporting. For 2020, it's back to 90 days. So the SLR is open, and it will be open all the way through March 31st. This is where the CTAP, the California Technical Assistance Program support, ends June 30th of 2020, though DHCS has been able to offer an extension through September 30th due to having lost some time because of the pandemic, that we're expecting that we can provide support through September 30th. But that's 6 months before the filing deadline for the program. But there's contractors out here that are able to help you between now and September 30th with 2020 if you want to, what I refer to often as an accelerated submission for your 2020 program year. If we do that, if you submit before July, we can help you through jumping through some of the hoops on the pre-qualification. And then for 2021 program year, it is expected that you can start your submissions April 1st of 2021 and sometime through August or September of 2021, which is not that long from now. It's about 18 months or so. So we can do 2020 now. You can do 2020 all the way through March of 2021. And then you have another program year of 2021, which would then be a slam dunk need to do it fast, where you do need to meet all of the requirements. But this is how you can earn those revenues that I showed in my Dr. Smith hypothetical scenario. What if you haven't touched meaningful use for years, or 2018 came, you saw the upgrade needed to 2015 edition cert, you saw stage 3 was on the horizon, your leadership decided that there was no longer a return on investment and that you had other initiatives to get onto. There is still the CTAP resources out here. So I've added the links from DHCS's website of the 4 contractors, CalOptima, High Tech LA, Object Health, and CalHIPSO. So you can reach out to any of those. You can reach out to me if you need to get connected to the other 3 contractors. We work together a lot. I'm happy to connect you if you don't fall in the geography that CalHIPSO helps under the CTAP. Some of the things that we help folks with, this is not the limited list, but the participation history, the eligibility, how to do group eligibility. Really big one is the meaningful use analysis. Are you passing, or are there gaps, and how do you correct those gaps? The clinical quality measures and security risk analysis. So just some of the things that the CTAP contractors are out there to help you with today, but it's a short It's a short leash because the program ends in September. Components of meaningful use. So stage 3, anyone attesting must meet stage 3. This is where a few years ago we had some folks in stage 1, some people in stage 2, some in the adopt, implement, and upgrade. The board is even now. Everybody's in stage 3. Even if they've only ever done 1 year of AIU, it's 0 to 60 now. They're in stage 3. That helps. Now we one benchmark for everybody. 2015 edition cert is required. Nearly everyone is upgraded onto 2015 edition cert, but you do need to be careful with that. Some of the EHRs out there got to that level or got through 2014, and then they could not make that final step to get 2015 certified. There can be also different components of your EHR that you might need. Are your clinical quality measures, do they satisfy 2015 edition cert? So again, the CTAP contractors can help you with that if you're not sure. There are 8 meaningful use objectives. So CMS, kind of a year or so ago, was pretty proud to talk about how they have drilled down stage 3 and it's only 8 objectives anymore. However, within those 8 objectives, there's 20 measures. And then a couple of the measures have a new component to them that never existed before stage 3, where you have to attest to all 3 of the measures, but you only need to pass 2 of them. So at the end of the day, you get down to 15 measures that must be passed to pass meaningful use for 2020, stage 3. As I mentioned earlier, it's still all or nothing. So if you fail 1 measure, you cannot meet meaningful use. This is why a lot of times when folks reach out to me to do a meaningful use gap analysis, I will hone in on 1 or 2 measures because I know what the difficult measures are and what many people are failing. And we know that's as far as we have to look. Unfortunately, if you can't fix that one, you won't be able to pass meaningful use. It is a little bit of a different complexity now that the 2 of the measures have passed 2 out of 3. So that gives you a little bit of hope if you are passing one or failing a measure. And then the clinical quality measures, a lot of the messaging will talk about the MU measures. A lot of your EHR reports will talk about the MU measures, but the clinical quality measures are a required component of meaningful use. And now some of my slides get a little frenetic. So this is a copy of the CMS table of contents, for which the link was on the previous page, and I have it as a resource at the end. I'm in this link daily. 7, 8 years into this, I'm still into this link daily. There's a different one for every program year, but I usually keep it active and live on my desktop throughout. These are the 8 measures, and they all have the different components. And the ones that I have flagged with the green arrows are what I'm essentially deeming as the easy measures. At the end of the day, nothing is really easy because if you take your eye off the ball, it's going to be easy to slip and miss one of them. And then you would fail meaningful use for not having met an easy measure. But most of these, we're doing well. We're using our EHRs meaningfully, and we're meeting the objectives and the thresholds. There's what I've flagged here are the exclusions. I try not to focus on the exclusions so that people are actually passing meaningful use so that it's meaningful as opposed to getting by the exclusions, but sometimes we do need them and they're there for a reason. CMS would not have granted exclusions. So everyone must protect patient health information. The electronic e-prescribing does have some exclusions if you write fewer than 100 prescriptions or if you live with further than 10 miles away from a pharmacy that does e-prescribing. The clinical decision support rule, that one's a little tricky because it has 2 measures and only one of the measures has an exclusion. So some people will think they can exclude through that, but they cannot. The CPOE, computerized provider order entry, there are exclusions offered, and the public health registries. Exclusions are offered, but I don't recommend that you take those. You want to be able to be, in this day and age, reporting to at least 2 of the clinical data registry reporting registries out there. I am not diving into these quote unquote easy measures today, but I don't want anybody to forget about them. the challenging objectives: patient electronic access, coordination of care, and health information exchange. One of the biggest things to note on this slide is the no applicable exclusions for the PEA, which is the patient electronic access, or the coordination of care. So they both have, between those two objectives, there's 5 measures, and there's no applicable exclusion. So some people think they can exclude through these, they cannot. The exclusion option does appear in the state level registry because, and I think I have it on another slide, there are exclusions, but they're not applicable. So it's really easy to click through the state level registry and choose the exclusion if you did not have a passing number, but the exclusion is not applicable, and DHCS analysts will catch that when they're reviewing your application. And then the health information exchange does have exclusions offered, and oftentimes many people need to use those. So now I'm going to go back for a second. I'm now starting a little bit of a deeper dive. It's still a lot more policy and information on the objectives as opposed to the technical workflow, but I'd like to get to that space if we have folks who are interested in meaningful use. So jumping into the PEA, patient electronic access to health information. So again, no applicable exclusions, and these are the 2 measures. For more than 80%, the patient must have been provided timely access to view online, download, and transmit his or her health information. And this part is new for stage 3, and it must ensure that this information is available through APIs, application programming interface. Your 2015 edition cert should have this built in, but it's something that you need to make sure. And then measure 2 is what used to be called patient-specific education. So this is the specification sheet from that CMS table of contents. Each of the 8 objectives has a link to the specification sheet, which can be anywhere from 2 to 6 pages long, but they have fantastic information in them. Some of the details of Objective 5, patient electronic access. So it's also known as VDT. So some of the key words or the acronyms are really helpful if you're talking to myself or to one of the CTAP or to someone from DHCS who's reviewing an application, or your EHR vendor. We might all use different terminology. So PEA, the portal measure, VDT. The stage 2 patient education measure is now measure 2 of this PEA. So somebody who's used to stage 3, who can't find patient-specific education might think, oh, good, it's gone. Nope, it's still here. It's just buried in this objective. And some good news out of the pandemic is that some folks have been reporting that because of the adoption of telehealth and the need to reach patients where they are, people are engaging more with their patient portal. So guess what? You might have failed this measure or this objective with 2019, but you already might have passed it because of what you needed, the heavy lift you needed to already undertake over the last 2 months. There are 2 measures, and you must pass both to pass meaningful use. And one of these measures has the 2 parts. And the exclusion, here is where the exclusions across the board, when my data, my slides and whatnot say not applicable, it's because they say no office visits during the EHR reporting period, which is typically applicable to a radiologist or an anesthesiologist, or does not have 50% or more of its housing units with 4 megabytes broadband availability. I abbreviated that section of the exclusion. But when you go to the FCC lists that show where those locations are, they're all in Alaska. They're not in California. There might be one in Utah, but there's none in California. Therefore, for I'd say 98, 99% of our EPs, because they're not typically anesthesiologists or radiologists, these exclusions are not applicable. But again, be mindful of that, because you can select that in the SLR and get to a passing meaningful use, which would later then either be rejected or denied or audited down the road, and you would be responsible for returning the incentive dollars. So Measure 1, for more than 80%, you need to have viewed it and use API. Your task is to find out what does your EHR vendor require for you to meet access and API. The arrows on the side of this slide and the upcoming slides are suggestions and words that certain EHR vendors use. So not everybody needs a token, but certain certified EHRs, that's the gate to getting into meeting, having your numerator increase for this measure. Web enabled, that's another one. Like if are your patient accounts web enabled, then then you're able to push the information to their patient portal account and meet this measure. And the API component might be in something called an interoperability hub. These are not by any means the only ways to get to this place. They're just kind of the hints for you to figure out what is specific in your EHR that will help you get to pass this measure. And then measure 2 is the patient electronic access for patient-specific education. This measure changed with stage 3. So not only did CMS move it from its own standalone objective and kind of bury it under PEA, but the material must now, in stage 3, which I don't think I have flagged in these slides, it must be provided electronically. So it's there right on that middle line of the description, the CMS words for this measure, provide electronic access to those materials. That is what's different with stage 3, and it's one of the components as to why people might have failed stage 3 back in 2019, because they did not change their workflow for the patient-specific education. You could still be giving the care instructions or the, here's information on diabetes. You can still be giving it in paper or via pamphlets like you did in stage 2 when you were able to pass, but you must also be providing it electronically. If it's not shared electronically with the patient, it will not trigger in your numerator. So some folks might say, I've been passing patient-specific education for 3 years now in stage 2. There is a difference with stage 3 because it must be provided electronically. That right there is a little bit one of the secrets as to why people failed stage 3. Alrighty, next objective. Objective 6, so coordination of care. We did not have an objective with this title prior to stage 3, no applicable exclusions. And this is one of the 2 measures objectives where you must attest to all 3 measures and must meet the threshold for at least 2 measures. So the State Level Registry will force you to do data entry on all 3 of these measures, but you only need 2 of them to have passed. An upside to something that CMS changed over the couple of years before stage 3 became the required stages, they did not increase the threshold. For a moment in time, these thresholds were higher, but they held them at 5%. So you need to, more than 5% need to actually access their health information. More than 5% need to have been sent or initiated a secure message, or patient-generated health information for more than 5%. And I go into each one of these in detail in the next couple slides. Let's see, I might have just covered all of this. This is another objective that, due to the recent adoption of telehealth, more people are engaged, and it does help with these measures. So that right there, again, could be a change between 2019 and 2020 that, without even knowing it, because of the adoption that many of you have taken of the uptake on telehealth in the last couple months, you already might have improved your odds for meeting meaningful use. And we all know by now, hopefully, that the exclusions are not applicable for most of us. So measure 1, you need to your patients actually need to view, download, or transmit that information that you made available under that other objective. So are they going into their patient portal and looking at it? At least 5%. So it's a very low number. It should be doable and it should be happening. And And this is a combination of, so they can do it through kind of the old school VDT, or they can do it through API. It doesn't matter. And or it can be a combination of both, and you still only need to get to 5%. So your task is to encourage your patients to access their patient portal. And you're going to pass this measure because it's 5%. I think you guys can get there if you're not already there. Secure messaging. So you can use campaigns and broadcasts. More than 5% of the EHR, a secure message was sent to the patient or their authorized representative. So we should be able to meet this measure. These are the types of things you need to be looking at now, and kind of if you plan to attest during the CTAP window of time, sooner rather than later. And if not, between now and September, make sure your workflow is happening so that you are meeting this measure. You can meet it. It's 5%. Early stage 3 rules had it that the patient needed to initiate the secure message. CMS listened to people and they said, okay, that was a little bit of a stretch. You can initiate it. So they made the measure easier. And I think you guys should be able to pass this measure as well. And then the third one is patient-generated health data. So for a while, a lot of people were not embracing this, and there's a lot of questions about it. You know, who's responsible for that data if it's come into your EHR and you have incorporated it? How do we know if the patient is including the accurate data so that it doesn't make a poor clinical choice? Are the devices secure? There's been lots of barriers, but CMS allowed that you only needed to attest to 2 out of 3. So if you do not want to adopt this, that's fine, you don't have to. Some of the ways you can adopt it are through a Helo Hub, patient questionnaire, NextGen, I think that NG stands for NextGen, online forms, or so there's a lot of different ways. And even today, because of the telehealth, there's a lot of patients who are self-reporting during the office visits, the telehealth office visit. They're self-reporting their blood pressure or their oxygen levels or their weight, height and weight. So there's a lot of different means of patient-generated health that if you're having problems with one of the other 2 measures, maybe you do want to do this, and maybe you're already passing it and you don't even know. So overall, coordination of care being quote unquote a new measure, a new objective for stage 3. The first 2 pieces of it are not new: secure messaging and actual use, the VDT. This patient-generated health data is new. There's a very good chance you're already passing this objective. And then this one is pretty much the doozy, the health information exchange. This is the objective that seems to be the barrier. You must attest to all 3 and pass at least 2. There are exclusions offered. The denominators for these 3 measures are slightly different when you read into the nitty-gritty of the specification sheet of this objective. The denominators are a little different, so therefore the exclusions they kind of read the same, but they really mean something different. And because you must pass 2, there are a couple different scenarios that allow you to get through this objective. So we've broken down every scenario we think is viable. And if you, unfortunately in 2019, a lot of folks on this objective failed 1 measure, met the exclusion for 1 measure, and passed 1 measure. But that scenario is a failing situation and you would fail meaningful use. Whereas everything on the left-hand side, you can pass meaningful use with these scenarios. You can pass 2 and fail 1. You can pass 2, exclude 1, pass 1, exclude 2, and so on. This slide has helped a lot of people have the clarity of what we're talking about when we hone in on this objective and say, okay, well, unfortunately, you did not pass meaningful use because you have failed 1, excluded 1, and passed 1. Or fail 1 and exclude 2. Sometimes people think because they meet the eligibility to exclude 2 that they have met this measure, this objective, and not the case. Alrighty, so breaking this one down into the 3 measures: sending electronic summary of care, For years, this has been the barrier. This is the challenge. We're hoping that the CalHOP program will help people get over the wall on this one. We're hoping that the push for interoperability and federal rules will help people get past this one. But in the short term, you can determine whether you need to pass this measure because you have measures 2 and measure 3 to pass that get you past the goal line. So if you cannot do measure 2 or 3, then you need to pass this one and dive into how. And this is the exchange of health information. We should be at this place in this day and age, and let's get there. Some of the ways to get there are direct trusts, P2P, next gen share, care everywhere. Those are just some of the key words, not limited to those, but you need to create the summary of care record using your certified EHR technology, and you need to exchange that record electronically. It's more than 50%. A lot of people struggled with the stage 2 threshold for this, and we're not able to pass. And if you're, I think I go straight to numbers. Again, I'm not focusing much on the exclusions, but if you have fewer than 100 transitions of care and referrals, then you can exclude. But again, don't get caught into excluding if you're not hitting one of these scenarios. So the second measure in this objective is more than 40% of transitions or referrals received and patient encounters in which the EP has never encountered the patient before, they incorporate into the patient's EHR an electronic summary of care document. So many people did pass this measure in 2019. There's some nuances in there with the word and whether it's incorporated and whether a summary of care document is available. I pulled from the specification sheet from CMS the actual definition of the numerator and denominator, and for especially in the denominator, and for which an electronic summary of care record is available. So if that summary of care record isn't coming in essentially via electronic means into your 4 walls, then that should not be in your denominator. So many did pass this one. A lot of people think that it's not, not something that they were doing or that they would be able to pass. And it also has the exclusion. If your denominator is fewer than 100, you can exclude from this. But you should review this. That's your task, your homework. You can probably pass this if you're not already, and there's some nuances in the terminology in the actual Federal Register rules where these specification sheets are excerpts of, and in the way the 2015 edition cert has been coded and programmed. So if you need help with one specific measure to get you over that barrier for passing meaningful use, this is a good one to dive into, and also to reach out to your CTAP contractors if you need assistance with that, or your EHR vendors, of course. And then measure 3. Unfortunately, this, in my opinion, and I did not do a statistical analysis on this, but from what I saw from basically like September or October through March 2019 through 2020, this is the most commonly failed measure of 2019. So folks knew they weren't able to pass measure 1. They flew through measure 2, no problem, and measure 3 caught them off guard. So they were not passing clinical information reconciliation. So that's the gotcha from the 2019 meaningful use, that even though, I think it goes into the next, sorry about that. So even though people are doing clinical reconciliation, they didn't pass this measure. So this is one to be looking at: med list, medication allergy, and current problem list. So it grew up a little bit between stage 2 and stage 3 from, it used to be called, I think it used to be called medication reconciliation. Now it's clinical information reconciliation. Previously, it did not include the component of the current problem list. And that is potentially the only thing that really tweaked the workflow that people did not know about. So this is one of the most important measures to be looking at because it's super passable. It's just, how is your EHR thinking? How does it work? Is there a new workflow that you need to adopt that will help you get to passing meaningful use, because you're probably really close. And we know that everyone is still doing these reconciliations, but are they getting the credit in the mapping of the meaningful use? Let's see, I'm going to pause for a moment to take a quick sip of water. And this information comes from, on this slide, slide 35, comes from the CMS specification sheet. So there's a lot of good additional information on the spec sheet, and I'm not going to read into it, but again, clinical reconciliation is an objective, is a measure that I would really like people to focus on. New workflows were needed with your 2015 edition, and a lot of people missed that memo. So something to look into and reach out to your EHR vendor. It was not isolated to one EHR for 2019. We saw it across probably 10 different popular EHRs where people did not know about a tweak in a workflow and failed that meaningful use. And we just think there's probably a couple things that need to be implemented that should not be too much of a burden. They should help make the work meaningful. And so my repeated task on this is that you can pass this measure, but you do need to be looking at it. And again, the CTAP contractors are out here to help you with that. Here's a summary of the list of, I'm not going to go through these, of all of them. So since I only focused on 3 out of the 8 objectives, I don't want anybody to forget that there are 8 and that some of them have these sub measures in them, and not to forget about the clinical quality measures. I've also used some of the state level registry terminology here because it does look a little different. So the CMS list may, or a CalHIPSO list may list the measures using one set of words. Your state level registry has words like ability, data incorporated into EHR that might not match what your EHR report looks like. So just know that there's a lot of crosswalking that you might need to do, and a lot of us out here can help you with that. So clinical quality measures, they are the component, and there are changes to clinical quality measures that came in a year or 2 ago, but a lot of people kind of were asleep at the wheel for this. And while the top of the messaging from CMS says you are EPs are required to report on any 6 clinical quality measures, some of you might remember that it used to be 9 and had to be from 3 different domains, or before that it had to be a core clinical quality measure, and then if not an alternate core, and then if not that. So CMS has revised it to any 6, but the any 6 have conditions. So one of them, at least one, has to be an outcome measure. If no outcome measure, then at least one has to be a high priority measure. And if there's no outcome or high priority, then you're allowed to report on any 6, but those 6 have to be relevant measures. DHCS does review the meaningful use applicant CQM submission by provider type. So they are looking to see whether the EP has attested to clinical quality measures that are relevant to his or her scope of practice. So if you're someone out there who has taken a couple years off of meaningful use, this is new. So you can't just choose the first top 6, even though the first line in CMS messaging is, oh, you're allowed to report on any 6. You have to keep reading. There is a document on the DHCS Medi-Cal Meaningful Use website that is a 2019 list. They are working on the 2020 list, but I'm pretty sure they are exactly the same. They should be really close, maybe a difference of 1 or 2 measures, if that, but I think they're the same, but you can reference a 2019 list. I took some snapshots out of the DHCS state level registry guide of how it's coded and what it looks like. So you'll get a screen that says, okay, here's your 6 outcome measures. If you're staring at your certified EHR clinical quality measure report and you don't see anything that's called CMS 122 or CMS 132, you can click those arrows in the state level registry and it will give you more detail, and you'll be able to crosswalk to your meaningful use report. But the attestation system is coded to first prompt you, do you have an outcome measure? If so, check the box to the right. You could possibly even check all 6, and that's going to cover your minimum of 6. Otherwise, you choose none and you click next. And then it will give you, this is the list of high priority measures. Same wording, like if you don't have any high priority measures, then you click next and you would select them if so. And then our state level registry DHCS has incorporated new requirements for better documentation. This is only going to help you years down the road if your meaningful use applications are called to an audit, because you are now required, starting with the 2019 program year, to provide this documentation. You're going to be in a better place tomorrow. But it is different, so a lot of people are not aware of it. So this documentation needs to include the meaningful use dashboard report. Right now, the state level registry and their guides and their information pages do not include that and the CQM report, but it needs to be included. They're looking for it, and if it's not included. So this started with 2019 attestations and is a new, it will be ongoing, so for 2020 and 2021. Some people spend their time uploading these reports per measure, and that can be really time consuming. It can be repetitive because sometimes they can't break out the report by measure, so they upload the whole thing. You can go through your entire attestation, and the state level registry will allow you to do it without uploading this documentation. And that's where this helpful hint is. You can do that, and then just once you hit submit, you can go back into the main dashboard for the EP and upload the documentation in one place. That can be a huge time saver. There's also the requirement for documentation of your security risk analysis. DHCS is looking for you to explain the methodology of your security risk analysis. They're not asking for you to upload an entire security risk analysis. If you want to do that, you can, but it's not what they're looking for. Like they don't want you to highlight and broadcast what your risks and vulnerabilities might be on an online portal, albeit it's a secure one. But they are requesting that you explain the methodology of your security risk analysis, and that's one objective I did not go into very much, but the timing of your security risk analysis is important. It needs to be done during the calendar year of the year for which you're reporting. If you completed a security risk analysis in December of 2019, and I have you motivated in May of 2020 to do your 2020 application, you still need to have reviewed and updated your security risk analysis for program year 2020. Pick up that one from December, review it, see if there's been any modifications or changes in the past 4 or 5 months, and then you can use the DHCS template to update the timing and have the documentation provided for that. This is new, so a lot of people who are not aware of this, another one of those kind of missed memo, totally understandable, that they're getting emails from the state saying this is a requirement and you need to upload this stuff. And a lot of folks are saying, I've been doing this for years and never needed it before. True, you didn't. You'll still need it if somebody goes back 5 years and audits like a 2014 application or something, but it's required now. So a summary, the attestation window is open. You might have already passed 2020 meaningful use. If you're not passing, let's figure out sooner rather than later why you're not passing, and there is still free technical assistance. The screen capture on the right is from the state level registry. It's what the objectives and measures look like when you're actually in the attestation system. All right, and Lauren, I'm going to jump to you for polling.
Okay, so we're going to go ahead and do our poll number 2.
Is there interest in the California State Level Registry, how to navigate webinar? I touched on the State Level Registry a little bit here, but as you have seen, there are some hints and tricks and tips that people are aware of. Again, I'm not going to put one of these together if we don't think a lot of people are jumping back onto the MU bandwagon, but we're happy to do it if there is some interest.
So it looks like we're getting a good amount of answers. They are starting to slow down. So I'm going to give you another 5 seconds if you want to get your answers in at the end here, and then we're going to close the poll down. Okay, so we're going to go ahead and close the poll and take a quick look at the results.
Great, thank you, Lauren. Okay,
Yeah,
thanks. And we do have a second poll question, I think, a third actually.
Our poll number 3 is going to come up right now.
Third and final. Is there interest in EHR vendor deep dives in the workflows that help eligible professionals pass meaningful use?
Okay, so answers are already starting to slow down. I'm going to give it 5 seconds to let anyone who wants to get their answers and get them in. Okay, and we're going to go ahead and close that poll.
Awesome. All righty. Thank you.
Yeah, absolutely.
Okay, this is where I jump back in and goes a little slow. So I have a little spiel for the conclusion. I do think that over the past 10 years, meaningful use has put us in a position to succeed with interoperability, getting health information safely and securely exchanged, and that meaningful use incentive dollars are still on the table. You have an opportunity to earn needed funding, and you really might be closer than you think. So tying this into whether promoting interoperability is meaningful, I hope I have demonstrated some of that today for you. And please reach out to me. Like I said, if you're not a CalHIPSO CTAP organization or eligible, I can help hook you up with the other contractors if you're not. And if you don't fall within CTAP but are eligible for Medicaid meaningful use, between myself and a lot of my counterparts out here, we'll do everything we can to help you guys earn some of the funding that is still available out there. There's some resources here for the open data portal. We'll be sharing this link for you. You can Google these keywords if you want them before our webinar deck is posted available online on our website. Just shoot me an email and I'll help save these, but I don't really even have them bookmarked, but these are the ones I talked and showed some examples from earlier. And we don't have a lot of time for questions, but I'm happy to see if Lauren sees any. I don't see any in the chat box, but it might just be my view.
So I'm actually not seeing anything on my side in our questions or chat box.
Alrighty, so if you have a question, feel free to throw it into the chat box right now. I don't know that we have a raise hand option, which is fine, but it's practically the top of the hour, and I definitely appreciate everybody coming. And if you need help looking towards at 2020 meaningful use, reach out. And myself, the CalHIPSO operates with local extension centers because we were originally called a regional extension center, who are our subcontractors. And if CalHIPSO, any of the local CalHIPSO local extension centers, which are Lumetra, Vigilance, the FQHC organizations, HQP, CCH, CHCN, the CVC, which is now part of OCHIN, we're out here. Redwood Health Coalition, I think I've covered everybody now. I apologize if I forgot, but we're out here to help you. And then the co-CTAP contractors are out here as well. And we would love to help you earn some incentive dollars to help offset some of the revenue losses you've been experiencing. And Lauren, have you also checked the question box as opposed to the chat box?
Yes, I have been looking at both of them.
Okay. Alrighty, well, it's 12:59. I'll give you back 1 minute, and these slides will be shared and made available for you once we have the download of the recording. And thanks a lot for joining today, and please do not hesitate to reach out. Thanks a lot. Be well.